CT scans in coronal plane with bone windows and soft tissue windows demonstrate extensive tumor, completely filling up the entire maxilla with expansion of its supralateral walls, and destruction of the alveolar process and the hard palate. There is no soft tissue extension in the pterygomaxillary fossa. A split-thickness skin graft is harvested first, using a dermatome. The skin graft will be utilized for lining the surgical defect after removal of the specimen. Adequate dimensions and thickness of the skin graft should be secured to provide sufficient skin to line the defect. A modified upper lip-splitting Weber-Ferguson incision with subciliary extension is employed to expose the anterior wall of the maxilla. The skin incision follows the curvature of the ala of the nose and splits the philtrum of the upper lip in the midline. The skin incision is deepened through the underlying musculature up to the anterior bony wall of the maxilla. As the cheek flap is elevated, an incision is placed into the mucosa of the upper gingivobuccal sulcus to provide mobilization of the full thickness of the cheek, all the way up to the posterior aspect of the maxilla. The subciliary extension is taken with a scalpel, remaining approximately 2 millimeters below the tarsal margin and following the curvature of the lower eyelid in a skin crease. Meticulous elevation of the delicate skin of the lower eyelid is undertaken with the use of an electrocautery, remaining superficial to the orbicularis oculi muscle, which is retained in its normal position with its nerve supply intact to preserve function. Delicate handling of the skin flap in this region is essential. Otherwise, skin perforations will occur, leading to the risk of necrosis of the skin flap in the post-operative period. This skin flap is elevated all the way up to the lateral canthus and up to the undersurface of the zygomatic arch laterally. Entry is made into the nasal vestibule by elevation of the ala of the nose over the anterior margin of the maxilla over its nasal process. A mucosal incision is made in the midline of the hard palate, extending from the alveolar process up to the junction of the hard and soft palate. This incision is extended laterally, posterior to the maxillary tubercle to connect with the cheek flap. Exposure of the pterygoid fossa is thus obtained, bringing into view the medial pterygoid muscle. This muscle is divided completely with the electrocautery to free up the maxilla from the mandible. Muscular, as well as tendinous fibers of the medial pterygoid muscle are meticulously divided, as shown in this close-up view.